Status Epilepticus on the Pediatric Ward by Nadine Abujaber.
Hi, I'm Nadine Abujaber. I'm a pediatric hospitalist at Boston Children's. Today we're going to learn about recognizing and managing status epilepticus on the pediatric floor. So our case, we have a patient. He's a 2-year-old with a history of hypoxic ischemic encephalopathy with subsequent developmental delay and a metabolic disorder resulting in hypoglycemia with fasting or illness. And for this, he gets continuous feeds via an NG tube. He's admitted to your service for G-tube placement in the morning. You're called by the nurse with complaints that he's tachycardic and demonstrating abnormal movements. So with this call, what should you be thinking about now? What's your differential diagnosis? Seizure, pain, infection, abnormal electrolytes, medication effect, and endocrinopathy. What are the most important questions to ask the nurse over the phone before even seeing the patient? 1, you have to make sure that the patient is stable. And 2, what are the length of time of his symptoms? Once you're in the room, what do? First thing, make sure the patient is on CVR and oxygen sat monitor. Your vitals on seeing the patient, temperature 37 degrees Celsius, a heart rate of 180, blood pressure 110/70, respiratory rate 30, O2 sat 86% on room air. A focused physical examination shows that the patient is not responsive to voice. He's sweaty, his eyes are deviated to the right bilaterally, he's drooling, he's tachycardic, but without any irregular rhythms. He has good aeration and good respiratory effort. His capillary refill is less than 2 seconds, and he has good radial and dorsalis pedis pulses bilaterally. And looking at him, he has tonic-clonic jerks of the body and extremities. So based on the vital signs and the physical exam, what would be red flags on your initial examination? If you see apnea, persistent hypoxia despite oxygen delivery, or hypotension. Now, based on your initial evaluation, what do you think this most likely is? Given the eye deviation, the poor response to stimuli, and the tonic-clonic activity of his body and extremities, this is most likely a seizure. What are the typical ways that seizure presents? You can see a change in vital signs, which includes tachycardia, tachypnea or apnea, or desaturations. There can also be abnormal rhythmic movements, as well as a change in mental status. So what are your initial steps in management? Always, your first priority is airway, breathing, and circulation. In this case, he has a patent airway, but is hypoxic, so he needs supplemental oxygen via a mask. He has normal blood pressures, good perfusion, and good pulses. After that's been stabilized, you need to assess, does he have IV access? So in this case, he has a peripheral IV in his right upper extremity. If he did not have an IV, there are other routes, including he has an NG tube, which can be used temporarily until IV access is obtained. And we often use rectal delivery of medication, but keep in mind, because of rapid redistribution, this can increase the rate of seizure recurrence. So now, what additional history should we collect to better understand why he's had a seizure? So ask about past history of seizures and management parameters if he has a seizure history. In this case, he has no seizure history. Does he have fever or other infectious symptoms? Because this can lower a seizure threshold. In this case, negative symptoms for an infection. Has the patient been started on any new medications, or has he missed any medications? This is especially relevant for someone with a seizure history and who is on anti-epileptic medications. Also, think about if a patient is on benzodiazepines or baclofen and is going through withdrawal. In this case, there were no new medications or missed medications. Has the patient had any vomiting, diarrhea, discontinuation of feeds? This helps assess for abnormal electrolytes, especially sodium and glucose. In this case, the nurse realizes he's been discontinued from his feeds in preparation for being NPO, but hasn't gotten his IV fluids yet. So based on your examination and the history, what laboratory data and/or imaging should you consider? So in this case, at D-stick, given his history of hypoglycemia when off feeds, and his feeds were unknowingly disconnected. Otherwise, you should consider CBC and blood culture if he's had an infection, a chemistry if there's a concern for low sodium or low glucose, AED levels if he has a seizure history. Imaging is typically not done unless there's a concern for head trauma or increased ICP, and in that case, you would obtain a head CT. But always make sure your patient has been stabilized prior to imaging. So what do we do next? You're at the bedside. The vitals are as follows. Temperature, 38 degrees Celsius. Heart rate, 175. Blood pressure, 100/65. Respiratory rate, 30. O2 sat, 98% on 5-liter face mask. He continues with a tonic-clonic movements and eye deviation. It has been 5 minutes. The nurse checks a D-stick and it's 25. The next step you should take, administer a dextrose bolus. The recommended doses are 0.5 to 1 gram per kilo IV. If you're giving D25, you give 2 to 4 mLs per kilo. If you're giving D10, the recommended dose is 5 to 10 mLs per kilo. Now, he's continuing, despite the dextrose bolus, with seizure activity. If a patient's been seizing for 5 minutes, you administer Ativan 0.1 milligram per kilo IV or IM, max dose of 4 milligrams. If there is no IV access, you can also give Diastat rectally 0.5 milligrams per kilo. If the seizure persists for 5 to 15 minutes, then you want to repeat the Ativan at the same dose of 0.1 milligram per kilo IV plus phosphenitoin 20 milligram PE per kilo. If the seizure persists for 15 to 20 minutes, then you give phenobarbital 20 milligrams per kilo IV. And if the seizure persists for 20 to 30 minutes, then you give phosphenitoin 10 milligrams PE per kilo. These are some special notes. If the patient has a past history of seizures, always know the seizure medication plan. If the patient, for example, is already on Keppra, we often will give a bolus of Keppra rather than Ativan. Another note is, when do we consult in neurology? I think we can consult neurology as early as warranted, but definitely if no response to medications by 10 to 15 minutes. Special considerations when managing seizures. So we already addressed hypoglycemia with this patient, but another special situation that can precipitate seizures is hyponatremia. And in that case, you want to give hypertonic sodium chloride 3% solution, 2 to 4 mLs per kilo IV in a slow push until the seizure stops. Then you give the remaining over 30 to 60 minutes. And it's always important to think in the back of your mind, when do we involve the ICU? So definitely thinking about involving the ICU if the patient is hemodynamically unstable, it has apnea and needing to support his respirations. If he's having a poor response to medications or persistent seizures, or we're needing to escalate care, giving phosphenitoin, for example. So to conclude this case, the patient received a D25 bolus and 1 dose of IV Ativan. His tonic-clonic movement stopped and his vital signs normalized. He was fatigued after this episode and slept. His feeds were restarted and his blood glucose were trended to ensure improvement. And this is the conclusion of this video. Thank you for watching, and I hope you learned about management of status epilepticus on the floor. Thank you.
Please help us improve the content by providing us with some feedback.